welcome you all for the another edition of Online Anesthesia, a postgraduate teaching program on Zoom platform, sponsored by Akrila and hosted by A1 Rajiks. Today we are having two eminent speakers among us. Dr. Sanjay Pandya is an international faculty and he is a nephrologist. He is going to talk about the acid-base balance and ABG interpretation. For us, the acid-base balance is a tough nut to crack, but for him it is a fun to learn. So it is going to be an interactive session. You can feel like a classroom experience. For that, we are having postgraduates from various medical colleges. The second speaker is having a vast experience in giving anesthesia for airway problems, Praveen Kumar. He is the best presenter that I have come across. And at the last, we have also quiz also to this episode. And with that few introduction, I call upon Dr. Gomadi to coordinate the session and introduce the speakers. Over to Dr. Gomadi.
A very good morning to all. And I'm very happy to introduce Dr. Sanjay Pandya. He's a leading nephrologist from Rajkot-Gujarat. And he is an author of Practical Guidelines on Fluid Therapy, a book which I also cherish very much. He is the founder of World Record Award winner website www.kidneyeducation.com, which tells you everything you need about kidney and its related diseases. It has 9 crore hits in 130 months and can be downloaded in 39 different languages for free. He will be giving us an interactive session along with the PGs. Over to you, Sanjay sir.
Good morning all. It's indeed a great pleasure to be here. A new experience with a new group of friends in different part of country. Thank you very much for giving me opportunity to talk to PG friends of mine. I really very much like to interact with students in different part of country. Now, first question, I mean, this is not a teaching session. This is going to be interactive session. And therefore, the first thing that I would like the question which I'm starting with, and the same question I will ask at the end, that how many of you find interpretation of acid-base disorder easy and difficult? Now, let your answer be with you. And then at the end of talk, again, I will review that how do you rate the same question. Now, see, basically, when we learn and read this acid-base disorder, it's difficult, it is confusing, it's complex. And the title which we have given, Fun to Learn Acid-Base Disorder, is something which is unbelievable, because how such a dry and difficult problem can be fun. So, but I assure you that today I am going to open the treasure from which you are going to have fun, and nothing but fun. Now, the subject is very wide, and today what I'm going to discuss is interpretation of how do we interpret ABG value report in day-to-day practice, and that's what I am going to do today. Now, why we need to know interpretation of ABG? Because it's to arrive right kind of the diagnosis which help us to plan the therapy in proper way. And if the patient on patients on ventilator, we need to make necessary changes on the basis of ABG report. So this is something, but don't get panic. See, physiological approach is simple, accurate interpretation is fun, and it's going to be life-saving in critically ill patient. These are the various headings under which I am going to discuss today's fun to learn interpretation. Now, see, when we want to learn ABG, remember 4. It's simple. Start with it. Let us start with basic thing. That remember 4. Why we need to remember 4? Because every value, pH is 7.4, so there is 4. Bicarbonate normal value is 24, so there is 4. PCO2 normal value is 40, so there is 4. So remember 4 and things are done. When pH is less than 7.35, it is acidosis. When pH is greater than 7.45, it is alkalosis. Now, when the values are in extreme range, that becomes life-threatening, and therefore we need to diagnose it properly and treat it properly. Now, the question arises that what determines pH? Answer is that there are only two factors which determines pH: bicarbonate, which is regulated by kidney, and PCO2, which is regulated by our pulmonary system. So only two things. There is no third parameter, and therefore I think our job is going to be very easy. So when bicarbonate is normal 24, when PCO2 is normal 40, then pH value will be normal, and that is 7.4. When pH decreases less than 7.35, it is acidosis. When it is greater than 7.45, it is alkalosis. So this is something which is basic thing. Now, in discussion, while reading this subject, whenever you see metabolic, say somebody says that there is metabolic disorder, that means they are talking about some change in bicarbonate. So when you see metabolic, think of bicarbonate. And when, so metabolic acidosis, metabolic alkalosis, that's where we interpret ABG. And when you see the word respiratory, think of some change in PCO2. It can be respiratory acidosis, it can be respiratory alkalosis. And likewise, we are going to discuss ahead. Now, first and foremost, we need to have basic information about primary disorder. So when we understand and discuss primary disorder, again, remember 4. Why? Because there are two disorders, which is metabolic, affected by bicarbonate change, that is metabolic acidosis and alkalosis, and two disorder because of primary change in PCO2, and that is respiratory acidosis and respiratory alkalosis. Now, this is a balance. When bicarbonate is normal 24, PCO2 is normal 40, then pH will be normal, and that is 7.40. Now, what happens in metabolic acidosis? Now, in metabolic acidosis, primary change occurs in bicarbonate. Now, when bicarbonate reduces, with reduction of the bicarbonate, even the pH will reduce, and that gives rise to metabolic acidosis. So primary change in metabolic acidosis is reduction of bicarbonate with resultant fall in pH. Now, why? In which clinical scenario we suspect and consider metabolic acidosis? Answer is that whether there is excess loss of bicarbonate, like in diarrhea, acid is added, like in diabetic ketoacidosis or lactic acidosis, or bicarbonate is not generated, like renal failure or renal tubular acidosis. Now, second disorder where primary change occurs in bicarbonate is metabolic alkalosis. In metabolic alkalosis, the primary change is increase in bicarbonate. Increase in bicarbonate will change the balance towards increase in pH, and therefore increased bicarbonate with increased high pH is the characteristic of metabolic alkalosis. Now, in metabolic alkalosis, why it happens? Why there is increase in bicarbonate? Answer is that there is excessive loss of H ion, like in vomiting, or there is failure of bicarbonate excretion by the kidney, which occurs in hypovolemia, hypokalemia, hypochloremia. Clinical problems like vomiting, diuretics, patient with hyperaldosteronism. So after two primary disturbances where bicarbonate changes, now coming to respiratory disorder, where primary change in PCO2, one of the first disorder is respiratory acidosis. If there is increase in PCO2, with increase in PCO2, the pH will reduce, and high PCO2 with low pH is the characteristic of respiratory acidosis. Now, why respiratory acidosis occurs? I have to learn from all of you anesthetists, because you are the one who look at this problem in day-to-day practice. Either it is neuromuscular problem with hypoventilation, or there is primary pulmonary disease with reduced excretion. Now, the basic question arises is that if there is a change in PCO2, why pH should fall? Answer is simple. CO2 plus H2O is carbonic acid. And when there is increased PCO2, even the carbonic acid increases, and that gives rise to acidosis. So these are the different causes where respiratory acidosis occurs. And the last amongst all, The second disorder where primary change occur in PCO2 is the respiratory alkalosis, where increased PCO2 will lead to high pH. So in respiratory alkalosis, the PCO2 will reduce. So reduction in PCO2 with increase in pH is the characteristic of the respiratory alkalosis. Why respiratory alkalosis occurs? Whatever may be the mechanism, but if there is hyperventilation, there is washout of CO2, and when there is washout of CO2, carbonic acid decreases, and because of the decrease in carbonic acid, it gives rise to alkalosis. So it may be neural causes, it may be pulmonary causes. All the causes are known to all of you. So this is the last disorder amongst 4. So to summarize, we have only 4 disorders when we talk about acid-base disorder. Metabolic disorders are metabolic acidosis with low bicarbonate, metabolic alkalosis with high bicarbonate, respiratory disorders, respiratory acidosis with increased PCO2, and respiratory alkalosis with decreased PCO2. So these are the basic things. Now to learn ABG interpretation, practice is important. And therefore, I request all of you to keep your pen and paper ready, because whenever we are going to discuss, you have to just write down and then you have to help me to solve the problem. So whenever you see flower in my slide, it's going to be time for all of you to reply. And I wish that all of you should reply together. I'm not going to ask to any single individual, but those who are even on YouTube should loudly reply, because this is a practice, and whenever you practice, you will learn in better way. So those who are with me, those who are on YouTube, everybody should loudly reply to all my questions, and that's how we are going to go ahead. So now we will start the practice. Okay, it's simple. It's very simple. Not simple. It's very, very simple. Diagnose expected acid-base disorder in following condition. If it is diarrhea, then what is the expected disorder? I request all of you to reply. We can keep some of the students unmute.
Metabolic alkalosis.
So it's metabolic acidosis. Vomiting is
Metabolic
alkalosis. Yeah, patient receiving diuretics. Yes, metabolic alkalosis. Shock.
Metabolic
acidosis. Metabolic acidosis. It could be lactic acidosis. And patient with respiratory failure.
Respiratory acidosis.
So I mean, such a simple way of discussion will be there today all throughout the webinar. Now, when we want to have step-by-step analysis of ABG, for the first time when we read this ABG report, we get confused that out of this, which values are important, which to interpret, which are not useful. So basic simple answer is that when we want to learn and interpret ABG, first look at the pH, second look at the bicarbonate, look at the PCO2, and regarding oxygenation, we are not going to discuss today. Okay, and don't forget, to interpret ABG properly, we need to have even serum electrolytes report simultaneously. Some of the ABG machines have inbuilt electrolyte analysis, and then it becomes easy for us. Now, first step is that we look at the value of ABG and find out, is there any disorder? So look at the pH, bicarbonate, and PCO2. If they are abnormal, that means we have some acid-base disorder. If they are normal, by and large, there is no disorder, but there may be some exceptions sometime. Okay. Now, if it is abnormal, first we need to find out that from looking at the pH, whether underlying problem is acidosis or alkalosis. So look at the pH. The normal value is 7.4. If it is less than 7.35, it is acidosis. If it is greater than 7.45, it is alkalosis. Okay. So it's something which is very simple. And when it's going to be flower, it's going to be your time to reply. So pH is 7.1. So what is the basic problem?
Acidosis.
Yeah, it's acidosis. 7.5. So it is
Alkalosis.
alkalosis. Okay. And 7.4 is
Normal.
Normal.
okay. Now, once we have decided, we have concluded that there is acidosis or alkalosis, the next question comes is that what is the primary disorder? Why there is acidosis? So if there is acidosis, then next step is that look at the bicarbonate. If the bicarbonate is low, our diagnosis is metabolic acidosis. See, there are only two possibilities. Look at the bicarbonate. If it is low, then metabolic acidosis. If bicarbonate is not low, look at the PCO2. And if the PCO2 is high, it is respiratory acidosis. So when there is acidosis, only two options. Why I said that it is simple? Because there is no third answer. So if we have low bicarbonate, our diagnosis is metabolic acidosis. If we have high PCO2, our diagnosis is respiratory acidosis. Okay, so it is something which is very simple. Likewise, if the pH is greater than 7.45 and if our diagnosis is alkalosis, again look at the bicarbonate. If the bicarbonate is high, our diagnosis is metabolic alkalosis. Or if it is not high, look at the PCO2. And if the PCO2 is low, our diagnosis is respiratory alkalosis. So for alkalosis, we have only two causes. With high bicarbonate, metabolic alkalosis. With low PCO2, respiratory alkalosis. So something which is very, very simple. So I will summarize that if we have low pH with low bicarbonate, our diagnosis is metabolic acidosis. If low pH with high PCO2, our diagnosis is respiratory acidosis. High pH with high bicarbonate, our diagnosis is metabolic alkalosis. High pH with low PCO2, our diagnosis is respiratory alkalosis. And now comes the flowers, and therefore it's going to be your time to diagnose primary acid-base disorder. See, we have simple rule. It's not always so, but for today's webinar, we have simple rule. Look at the pH first, bicarbonate second, and PCO2 last. And whenever you are replying, first speak the diagnosis of change in pH. It's acidosis. And then you will say that it's metabolic acidosis. It's alkalosis. Then you will complete the diagnosis by saying that it's alkalosis, it's respiratory alkalosis. For students, I am teaching, and therefore for them, this will be a simple method to learn. Now, this is the time you have to start replying me. There are questions, there are scenario where we need to know how we are, what is the primary diagnosis. pH is 7.48. So what is the primary problem?
Alkalosis.
Yes, it is alkalosis. Now, alkalosis is what kind of?
Metabolic alkalosis.
Because bicarbonate is high, so we have metabolic alkalosis. If we have alkalosis, there are only two reasons. With high bicarbonate, it is metabolic alkalosis. Low PCO2, it is respiratory alkalosis. Okay. Now, next case, 6.98 pH. So,
Acidosis.
acidosis. Which kind of acidosis is it?
Respiratory acidosis.
Respiratory acidosis because PCO2 is high. Okay, so it is something which is simple. Now 7.5 is the pH, so it is alkalosis. And which kind of alkalosis is it?
Respiratory
Respiratory alkalosis because PCO2 is low. Okay. 7.2 acidosis. And
Metabolic acidosis.
yes, because bicarbonate is low, it is metabolic acidosis. So diagnosing primary disorder is very, very simple. All of you replied very easily. Those who are on YouTube should also loudly speak because I am able to listen even to all of them. So you shouldn't feel that your answer is not reaching to me. It's also reaching to me. So everybody should loudly reply to my questions. Okay. Now we have made the primary diagnosis. What is the next? Next step is to diagnose mixed disorder. Now, to diagnose mixed disorder, we need to understand the concept of compensation. So what is compensation? See, now I'm not asking question because when there is no flower, you need not reply. You have to keep yourself mute. I will have some small discussion followed by few questions. That's how we are going to have fun to learn acid-base disorder. Okay. Now, when we want to learn about compensation, again, we have some question that what is compensation? What is same direction rule? What is expected compensation? And why to calculate and check compensation? To start with, we will discuss that what is compensation and how it occurs. See, if we go to snow mountain, then it will be cold. We would like to have a coat, cap, and gloves and everything to protect ourselves. But if you go to see pyramids in Egypt, you would like to have thin white shirt. So that is what is the compensation to protect ourselves from change in the temperature. Likewise, what is compensation in ABG? It is the body's defense mechanism which tries to maintain pH towards normal in various insult on pH homeostasis. Now, to maintain pH, we have three systems of defense: buffer system, respiratory, and renal. Okay, even in defense, we have three systems. So in the same way, in acid-base disorder also, we have three systems which acts. Now, when there is metabolic disorder, the primary change occurs in bicarbonate and compensation occurs by respiratory change. Okay. And when we have respiratory disorder, kidney will try to make change in bicarbonate and compensation occurs. Okay. Now, the change in metabolic acidosis, the respiratory compensation is fast. While in respiratory disorder, the ability of kidney to make change in bicarbonate and to compensate is slow. That is something we need to remember, because compensation, when we look at further analysis, this matter is going to be useful to us. Now, how compensation occurs? This is the example that in metabolic disorder, we have respiratory compensation. Low bicarbonate and low pH will be feature of metabolic acidosis, and low pH will stimulate respiratory center. There will be hyperventilation known as Kussmaul's breathing that will wash out CO2, and low PCO2 will bring the pH towards normal side. And that is what is the compensation. So the primary change was reduction in pH, and compensatory low PCO2 will try to bring pH towards normal. And this is what is the compensation. Now, the next question, what is the same direction rule? When the compensation occurs, the change in bicarbonate and PCO2 occurs in the same direction. Decreased bicarbonate leads to decreased PCO2. Increased bicarbonate leads to increased PCO2. Up yields up, down yields down. This is known as same direction rule. Does it applicable to all four primary acid-base disorder? Answer is yes. It is true for metabolic disorder as well as for respiratory disorder. It is true for all four disorders. So this is known as same direction rule. Now, what is expected compensation? Is we have learned that suppose patient has metabolic acidosis and bicarbonate from 24 has reduced to 16, then we do expect that PCO2 will reduce. But from 40, will it be 30? Will it be 20? Answer is that we need to know formula about the same. So what are the expected compensation and what are the formula used? Now, for metabolic acidosis, the formula is Winter's formula, which is very simple. Now, I want all of you to speak loudly with me that in metabolic acidosis, PCO2 is equal to 1.5 times bicarbonate plus 8. PCO2 is equal to 1.5 times bicarbonate plus 8. Loudly speak along with me. PCO2 is equal to 1.5 times bicarbonate plus 8. Yes, PCO2 is equal to 1.5 times bicarbonate plus 8. Okay. Yes. Done. Yeah, done. Okay. Now we are going to have exercise. Okay. So although there is no flower, I just missed it. We will have exercise. So if patient has metabolic acidosis and bicarbonate is 20, what will be the expected value of PCO2?
38.
1.5 times bicarbonate plus 8.
38.
So for 20, it is 38. For 16, it will be
32.
32. And for 10, it will be 23.
20.
Okay. So very, very simple. In metabolic acidosis, to calculate compensation, it is 1.5 piece. The value compensated value of PCO2 will be 1.5 times bicarbonate plus 8. Okay, so remember 1.5 times bicarbonate plus 8 and work is done. Now, when it comes to metabolic alkalosis, what is the formula used? Now here, we said that as per same direction rule, when bicarbonate increases, even PCO2 will increase. But how much PCO2 will increase? Answer is that PCO2 rise is equal to 0.6 into bicarbonate rise. Okay? PCO2 rise is equal to 0.6 into bicarbonate rise. I request all of you to speak loudly. PCO2 rise is equal to 0.6 into bicarbonate rise.
For every 1 milli.
Okay. So this is what is the simple thing, and complete compensation occurs within 24 to 36 hours. Now, here are the questions. Okay, here are the questions. Let us calculate the expected PCO2 value in metabolic alkalosis with bicarbonate of 30. So what will be the value of expected PCO2 when bicarbonate is 30?
43.6.
Yes,
43.6.
3.6 and therefore 43.6. Likewise, we will calculate for both 34
40 plus 4, 46.
46.
Plus 6, 46.
and for 44 it will be 50. Okay, so remember that PCO2 rise is equal to 0.6 into bicarbonate rise. So add this rise in 40 and you will get the expected value of PCO2. So to summarize, in metabolic acidosis,
PCO2
is equal to 1.5 bicarbonate alkalosis PCO2 rise is equal to 0.6 bicarbonate rise. Okay, fine. Now your turn is over. So again, I will revise that in metabolic acidosis, PCO2 is equal to 1.5 times bicarbonate plus 8. And in alkalosis, PCO2 rise is equal to 0.6 into bicarbonate rise. Okay. Now comes the respiratory compensation. After metabolic, how do we calculate? See, some of the figure in some of the literature differs, but this is by and large a simple way of learning, because if you will read some of the book, then there may be some change. So forget about it. You should have simple, basic take-home message. Okay. Now, for respiratory compensation, how do we calculate? It's very, very simple. Not simple. Very, very simple. For remember 1,4 and 2,4. Rule for change in 10 mm of PCO2. Remember 1,4 and 2,4. So what is this 1,4 and 2,4? Answer is that when we want to calculate respiratory acidosis, remember 1,4. So what is this 1,4? Answer is that, see, we have discussed that the compensation for respiratory disorder is done by kidney, and kidney takes the time. And therefore, when there is acute respiratory acidosis, the change in bicarbonate occurs little low. But with the time, kidney can manage to get compensation to great extent, and therefore the value of compensation is going to be much better in respiratory, acute respiratory acidosis. It will be a low, small rise, while in chronic respiratory acidosis, with the time, compensation occurs more. So if we look at the acute respiratory acidosis, with every increase of 10 mm of Hg PCO2, how much will be the rise in bicarbonate? Answer is that it is only 1. Okay, so out of 1,4 in acute respiratory acidosis, we have 1 formula with us, and therefore, suppose patient has sudden onset respiratory acidosis, and if the value is 60, then what will be the expected value of bicarbonate? How much will be the rise in bicarbonate? Answer is that bicarbonate rise is equal to 0.1 into PCO2 rise. If it is 60,
26.
then calculate
26.
0.1 into 20 is equal to 2. 24 plus 2 is equal to 26. If it is 80, then it will be 4. 24 plus 4 is equal to 28. If it is 110, then 0.1 into 70, so addition will be 7, and therefore 24 at 7 is equal to 31. And therefore, when we have respiratory acidosis, it is 1. But what is 1,4? Answer is that in respiratory acidosis, you have to remember 1,4, that if it is acute, the rise in bicarbonate will be only 1 milliequivalent per liter for increase of 10 mm of Hg increase in PCO2. But when it amounts to chronic respiratory acidosis, kidney does the job properly, and for every 10 mm of Hg increase in PCO2, bicarbonate will increase by 4. And therefore, with same figure, if you will calculate the expected value of bicarbonate will be different. If it is 50, then how much will be the rise in bicarbonate? Answer is that rise in bicarbonate will be 4, and value of bicarbonate will be 28. If it is 60, then 0.4 into 20 is equal to 8. 24 plus 8 is equal to 32. And if it is 70, it will turn out to be 36. And therefore, this is how we calculate 1,4 for acute respiratory acidosis and 4 for chronic respiratory acidosis. So always remember 1,4,2,4 for respiratory acidosis, it is 1,4. For respiratory alkalosis, it is 2,4. So when it is acute respiratory alkalosis, for every 10 mm of Hg PCO2 fall, we have to multiply by 2, not by 1 or 4 like acute respiratory and chronic respiratory acidosis, and then we will get the bicarbonate fall. So this is how we calculate. If it is 30, if the reduction is by 10 mm of Hg, 0.2 multiplied by 10. So fall in bicarbonate will be 2 milliequivalent per liter. 24 minus 2 will be 22. If it is 25, that means fall in PCO2 is 15 mm of Hg. So 15 into 0.2 will amount to 3. 24 minus 3 is equal to 24. And this is how we calculate in acute respiratory alkalosis. So in respiratory acidosis, remember 1,4. In respiratory alkalosis, remember 2,4. This is how we calculate. It is something which is very, very simple. If we calculate for chronic respiratory alkalosis, this is the example that if it is 30 for every, instead of 0.2, it is 0.4. And therefore, the value of bicarbonate will be much lesser and will compensate acid-base disorder, try to bring pH towards normal. So to conclude, respiratory disorder, we will say that in acute respiratory acidosis, remember 1,4. In respiratory acidosis, Acute and chronic is 1-4. In respiratory alkalosis, acute and chronic is 2-4. So remember 1-4 and 2-4 and you have done. So to summarize the compensation in metabolic acidosis, PCO2 is equal to 1.5 times bicarbonate plus 8. Metabolic alkalosis, rise in PCO2 is equal to 0.6 into bicarbonate rise. Respiratory acidosis, remember 1-4. Respiratory alkalosis, remember 2-4 and done. Now we spent about 5-7 minutes in discussing, understanding compensation and its calculation. So the question arises that why so much of the efforts? Why? What is the benefit? Why to calculate and check compensation? Answer is that it is to differentiate simple from mixed disorder. If actual value matches with expected or calculated value, disorder is simple. But if the actual value is either greater or lesser, then it suggests mixed disorder. And remember that compensation follows same direction rule. Up yields up, down yields down. If the changes are in opposite direction, think of mixed disorder. With this, the concept of compensation is done. All of you with great understanding is ready to go ahead with approach to mixed disorder. This mixed disorder looks like complex chess, but it's going to be very simple. So what is mixed disorder? The mixed disorder is volcano on snow mountain. What is the temperature? What is the temperature? Answer is that it is mixed because volcano will have increased heat. The snow mountain will have chilling cold, and when they are together, it's going to be a mixed disorder. So what is mixed acid-base disorder? It is defined as independent coexistence of more than one primary disorder. Mixed disorder occurs in very ill critical patient, and commonest is metabolic acidosis with respiratory alkalosis. Now, let us, before going ahead, let us have some example that when do we expect, in which clinical scenario we get this mixed disorder, metabolic acidosis with respiratory acidosis. Answer is that patient with shock heading for respiratory failure. There will be combination of the both. Diabetic ketoacidosis in severe COPD will have both. Likewise, there will be combination of different disorders, which I'm not going to discuss. That's available in the book. But one question which I have in my mind is that can we have metabolic acidosis and metabolic alkalosis together? I think no, because metabolic acidosis increases, metabolic acidosis decreases bicarbonate, while metabolic alkalosis increases bicarbonate. And there cannot be combination of metabolic acidosis and alkalosis, but my thought process is wrong. My thought process is wrong. Diabetic ketoacidosis having vomiting will have diabetic ketoacidosis due to diabetic ketoacidosis, and vomiting will give rise to metabolic alkalosis. In the same way, patient with severe vomiting presenting with shock, vomiting will give rise to metabolic alkalosis, and because of shock, there will be lactic acidosis. So, such patient will have near normal pH and bicarbonate. But metabolic acidosis and metabolic alkalosis do exist in many of the patients in clinical scenario. But it's very, very important. All of you know that respiratory acidosis and respiratory alkalosis never coexist. Okay? With this all basic concept, now we are going ahead, and then comes the diagnosis of mixed disorder. Okay? Now, when we want to learn the mixed disorder, the first and foremost, I would like to have let you know magic trick to diagnose mixed acid-base disorders. See, with this magic trick, just in 5 seconds, you can pick up mixed disorders. And what is this magic trick? It is Is it possible to diagnose mixed disorder quickly and easily? Those who are with me today, answer is yes. But those who are not with me will find it difficult and easily. Answer is simple. Answer is very simple. Check direction of changes. It will take just 5 seconds. If the direction of changes are, say, if you look at the same direction rule, then in primary disorder, the change in primary change and compensatory change occurs in the same direction. This is known as same direction rule. And therefore, if we look at the direction of changes as per same direction rule in simple acid-base disorder, bicarbonate and PCO2 changes from normal in same direction. Okay? But if changes are in opposite direction, our diagnosis is mixed disorder. So we don't know which mixed disorder, but we have suspected that yes, instead of same direction, they are in opposite direction, and therefore this patient is having mixed disorder. And then we need to work up more. So this is a magic formula. We just take 5 seconds to diagnose that whether it is mixed disorder or not. And therefore we have exercise. You have to just say that it is mixed disorder or same direction. Okay. So you have to, now it's going to be your time. You have to tell me whether it is mixed disorder or same direction. 20 and 50.
Mixed disorder.
Yes, it is mixed disorder. 34 and 48. Same direction or mixed disorder?
Same direction.
Yes, same direction. 12 and 60.
Mixed disorder.
Yes, it is mixed disorder because they are opposite direction. And 1838. Yeah, both are low. So it is same direction. And 28-28. It's like 20-20 cricket match. Answer is that digits are same. Digits are same, but direction is
Opposite.
opposite, and therefore it is a mixed disorder.
Mixed disorder.
So very, very simple first step. Look at the direction of changes. If they are in opposite direction, we have to think of some underlying mixed disorder. Okay. Now, what next? The next we have suspected, and then how do we go ahead? Answer is that calculate compensation. Okay, calculate compensation to diagnose mixed acid-base disorder. Now, how do we calculate and how it is useful? The formula, all of you are well aware of it. Now, with this formula, when we have calculated, and if calculated value and actual value are matching, disorder is simple. But if calculated value and actual value differs, that means we are dealing with mixed disorder. Again, I would like to revise what all of you have learned very well, that in metabolic acidosis, PCO2 is equal to 1.5 times bicarbonate plus 8. In metabolic alkalosis, rise in PCO2 will be 0.6 into bicarbonate rise. In respiratory acidosis, remember 1.4. In respiratory alkalosis, remember 2.4. And with this revision, now it's going to be your time to diagnose mixed disorder step by step. I request all of you to reply me step by step, not everything together. pH is what? Suggestive of what?
Acidosis.
Acidosis. Which kind of acidosis?
Respiratory.
Respiratory acidosis.
Respiratory or metabolic?
Respiratory.
Respiratory acidosis. Direction of changes are same or opposite?
Same.
Same or opposite?
Same direction.
Opposite.
Same
direction.
Yeah, both have increased, so it is same direction. Now, this is a acute event and it's acute respiratory acidosis. So, which formula will you use?
Acute event.
1.
Yes,
Two.
so you will use formula of 1. Out of 1.4, you will use 1. Okay. So, 0.1 into rise in PCO2. So, how much will be the rise in PCO2? Sorry, rise in bicarbonate.
Bicarbonate 7, 20 plus 1, 27.
7.
Yeah, it is 7. And therefore, what will be the expected value of bicarbonate?
4 plus 7, 31.
Yes,
31.
so it is 7. Rise in bicarbonate is 7. Expected value will be 31. Okay. Now, actual value is 27, which is lesser than expected value, which is 31. Now, it should be 31 to 31. Okay, if it would have been simple disorder. But instead of 31, the actual value is lesser. Actual value of bicarbonate is lesser. So, which condition reduces the bicarbonate?
Metabolic acidosis.
Metabolic acidosis. And therefore, what is the likely coexisting problem? Metabolic acidosis. So, with this calculation, instead of 31, when bicarbonate is lesser 27, that means there is coexisting additional presence of metabolic acidosis. So, with this calculation, we could diagnose that yes, this patient having respiratory acidosis also has coexisting metabolic acidosis. Okay. 7. pH is 7. So, what is the diagnosis? Acidosis. Now, which kind of acidosis do you think is this?
Metabolic acidosis.
Bicarbonate is 10 and therefore it is metabolic acidosis. Direction of changes are same or opposite?
Same side.
Same. Yes, both has reduced. Now, our diagnosis is metabolic acidosis. So, which formula will you use?
Test formula.
Yeah. So, it is 1.5
bicarbonate plus 8.
23.
So, yeah. So, expected value of PCO2 will be how much?
23.
23. Now, this actual value of PCO2, which is 23, and actual value is 36. So, instead of 23, actual value is 36, much greater. That means there is accumulation. Yes, there is accumulation of PCO2, and that happens in
respiratory acidosis.
Respiratory acidosis. And therefore, with this formula, we could diagnose that this patient is having metabolic acidosis with respiratory acidosis. So, by calculating and comparing, you can clinch the diagnosis of mixed disorder. So, first, diagnose mixed disorder, we check direction of changes, then we calculate compensation and look at the value, actual value and expected value, and try to derive that is there simple disorder or mixed. Now, what comes next? See, everything is done. Now comes the special skill to diagnose mixed disorder, and that is CID skill. Okay. So what is CID skill to diagnose mixed disorder? Answer is that check anion gap. Check anion gap to diagnose mixed acid-base disorder. So what is anion gap? Anion gap is sodium minus total of chloride plus bicarbonate. Anion gap is sodium minus total of chloride plus bicarbonate. I wish all of you to loudly speak twice. What is anion gap?
Sodium minus chloride plus bicarbonate.
Yes, sodium minus total of chloride plus bicarbonate. Okay, and its normal value is 12 plus or minus 2. But when we check anion gap, if the anion gap is high, it is diagnostic of hidden high anion gap metabolic acidosis. So CID skill is to check anion gap, and if anion gap is high, it is suggestive of high anion gap metabolic acidosis. Now, anion gap is called footprint in literature, and this footprint and fingerprint is taken by CID people, and that's the reason I have labeled this as a CID skill. And when there is metabolic acidosis is divided into two parts. I mean two groups, normal anion gap and high anion gap. Normal anion gap is hyperchloremic metabolic acidosis, which does not have high anion gap, and therefore there is no footprint. But when the anion gap is high, metabolic acidosis with high anion gap, like lactic acidosis, diabetic ketoacidosis, alcohol related acidosis. These all acidosis will have high anion gap, and with this high anion gap, we can clinch the diagnosis of high anion gap metabolic acidosis, which may not be obvious otherwise. Okay, and to calculate it, we need to look at the albumin. Decreased albumin will lead to increased anion gap, and for every 1 gram per dl fall in albumin, anion will increase by 2.5. So this is how we calculate. As I was saying, that this calculating anion gap is important, because if anion gap is normal, we have causes like severe diarrhea, renal tubular acidosis, urinary diversion, large volume of saline infusion. If we have high anion gap metabolic acidosis, ketoacidosis, lactic acidosis, renal failure, and toxic material ingestion. So these are some of the basic things. Now, if you remember this slide, I had put it even previously, that do not forget to interpret ABG properly, perform serum electrolyte simultaneously. Why? Why we want to have serum electrolytes? Because if you want to have CID skill, anion gap is a sodium minus total of chloride plus bicarbonate. So if we have sodium, if we have chloride, that means if we have electrolyte, then only we can diagnose, we can calculate anion gap, then only we can have CID skill, and therefore always go for serum electrolyte simultaneously. If anion gap is high, that means we have high anion gap metabolic acidosis. To emphasize the point, I will say that ABG and electrolyte are made for each other. If they are together, they are complete, they gives us complete diagnosis, and therefore always perform ABG and electrolyte simultaneously. With this, we would like to go ahead with more questions where you are going to reply me. pH is 7.4, so loudly please let me know that what is the disturbance.
pH.
Normal. Bicarbonate is 25, so is it normal or abnormal?
Normal.
Total is 40, whether it is normal or abnormal.
Normal.
Okay. So vomiting in diabetics with all 3 parameters normal, that means we don't have any problem in this patient. Do you agree or you don't agree?
Don't agree.
Not agree. Why? On which point you have disagreed with my
Ketone positive.
yes, ketone positive. And therefore, which skill will you use?
Anion gap.
Yes, CID skill, anion gap. Anion gap is sodium minus total of chloride plus bicarbonate. And how much is anion gap here?
20.
20.
20.
Mathematics
20.
is poor.
20. 30.
Yes, the mathematics of 30 is right. Mathematics of 20 is poor.
30.
30. And what is normal anion gap?
12 plus or minus 2.
12 plus or minus 2. So this anion gap is high, suggestive of what?
High anion gap.
It is suggestive of high anion gap metabolic acidosis. Now the question arises that if patient has high anion gap metabolic acidosis, why all 3 values are normal? Answer is that because of high vomiting. See, it's not compensation. It's not compensation, but there is coexisting vomiting which leads to metabolic alkalosis, and diabetic ketoacidosis leads to metabolic acidosis. So there is one parameter will try to increase the bicarbonate, that is metabolic alkalosis due to vomiting. Other parameter coexisting disease is diabetic ketoacidosis, will try to bring down bicarbonate and lead to metabolic acidosis, but both are neutralizing each other, and therefore this patient have metabolic high anion gap metabolic acidosis and metabolic alkalosis, and this you could diagnose with CID skill by measuring anion gap. So measuring anion gap is important. So while interpreting ABG, suspect, diagnose primary disorder, magic formula, check direction of changes, calculate and compensate. Then comes the CID skill, that is to calculate NIN gap. And now last part of today's story, and that is to diagnose a triple disorder, which to you seems to be difficult, but all of you are ready. All of you are now bright with all complete information and calculation formulas in your mind. And therefore, after CIDs at the next level comes is the skill, which is even greater skill, and that is Mossad skill. So final of the final, today's last part of my interpretation of fun to learn acid-base disorder is the Mossad skill. So what is the Mossad skill? In high NIN gap metabolic acidosis, see, remember the word. In high NIN gap metabolic acidosis, see, Mossad people will not listen to a phone of mine or Edward sir. They will take case only from CID. So if NIN gap is high, if there is high NIN gap metabolic acidosis, then only comes the Mossad skill. If NIN gap is normal, no Mossad skill. Okay, so calculate NIN gap, CID skill. If it is high, then go for Mossad skill. What is Mossad skill? Compare rise in NIN gap with fall in bicarbonate. So the question arises that what is rise in NIN gap? The rise in NIN gap is equal to actual NIN gap minus 12. So the value which we have calculated in patient minus 12 is rise in NIN gap. So to make your concept clear, we will have practice because it's flower, it's going to be your time. So if the calculated NIN gap is 26, what will be the rise in NIN gap?
14.
14. For 30, it will be
18.
14.
yes. So
18.
remember this. All of you, those who are with me and answering me even in YouTube, see, 26 minus 12 is equal to 14 will be the rise in NIN gap. If the NIN gap is 30, then 30 minus 12, so rise in NIN gap is 18. So rise in NIN gap is equal to actual NIN gap value minus 12. And in Mossad skill, we compare rise in NIN gap with fall in bicarbonate. So what is fall in bicarbonate? It is simple, 24 minus the value of bicarbonate we have in ABG. Just a little practice that if the value of bicarbonate is 20, fall in bicarbonate will be 4. And if 16, it is 8. So this is how we calculate. It is something which is very, very important. So again, I will say that Mossad skill is compare rise in NIN gap with fall in bicarbonate. In literature, it is also known as delta gap. It is also known as delta ratio. So whatever way you want to remember, but the way in which we are going to discuss is going to be very simple. So remember whatever best you feel. Now, Mossad skill is in high NIN gap. Remember, it is in high NIN gap, metabolic acidosis. Compare rise in NIN gap with fall in bicarbonate. So the question arises that how it helps. Answer is that in pure high NIN gap metabolic patient, rise in NIN gap and fall in bicarbonate both are same, both are matching. Okay. So if both values are matching, that means we have pure high NIN gap metabolic acidosis. But if as compared to rise in NIN gap, see, rise in NIN gap is this much. As compared to that, if the fall in bicarbonate is less, so if it is this much rise, but if fall is small, see, we are expecting that rise in NIN gap and fall in bicarbonate should be similar. But if the bicarbonate fall is less, that means there is a disorder which aids bicarbonate in patient's value. And which disorder aids bicarbonate? Answer is that it is metabolic alkalosis. So when there is metabolic alkalosis, the added bicarbonate does not allow bicarbonate to fall in the same magnitude as rising anion gap. So if rising anion gap and fall in bicarbonate are same, that means it is a simple disorder. But if the bicarbonate fall is less, that means there is additional bicarbonate added. And metabolic alkalosis is a disorder which adds bicarbonate, and therefore in massage skill, if as compared to rising bicarbonate, as compared to rising anion gap, if the fall in bicarbonate is smaller, that is suggestive of coexisting metabolic alkalosis. Okay, so this massage skill help us to diagnose hidden metabolic alkalosis. Now, the last part of today's discussion, that as compared to rising anion gap, if the fall in bicarbonate is more, that means bicarbonate instead of both should be this much, but the fall in bicarbonate is more, that means there is some disorder which reduces bicarbonate further, and that is coexisting normal anion gap metabolic acidosis. As we had discussed, the metabolic acidosis has two parts. One is high anion gap like lactic acidosis, diabetic ketoacidosis. So if there is in a high anion gap, this may be underlying problem. If there is coexisting, this patient develops diarrhea, then instead of equal rise in anion gap, with the equal fall in bicarbonate, diarrhea will lead to additional fall in bicarbonate. And therefore, as compared to rise in anion gap, if the fall in bicarbonate is more, think of coexisting normal anion gap metabolic acidosis. So this is what is the massage skill in high anion gap metabolic acidosis. Compare rise in anion gap with fall in bicarbonate. If both, and therefore, as we have discussed, as compared to rise in anion gap, if the fall in bicarbonate is greater, think of more normal anion gap metabolic acidosis. This massage skill helps us to diagnose hidden normal anion gap metabolic acidosis. It helps us to diagnose triple disorder. So compare rise in anion gap with fall in bicarbonate, which help us to detect hidden gain. Gain occurs in metabolic alkalosis, and therefore fall in bicarbonate reduces, or hidden loss. When there is hidden loss, fall in bicarbonate will be more, and that helps us to diagnose triple disorder in patient with acid-base disorder. So it's important to remember that difference more than 5 is significant. If it is just 1 or 2, it's not significant. Okay. So again, I will summarize that when, see, massage skill is only when there is high anion gap metabolic acidosis. And when we compare rise in anion gap with fall in bicarbonate, if both are equal, we have pure high anion gap metabolic acidosis. But if it's not equal and fall in bicarbonate is smaller, that means there is hidden bicarbonate gain, and therefore it is suggestive of hidden metabolic alkalosis. Okay, so if the fall in bicarbonate is less, it's hidden metabolic alkalosis. And if the fall in bicarbonate is greater, the fall is much more, that means there is additional disorder which leads to bicarbonate, and that is normal anion gap metabolic acidosis. So this is the concluding slide. Okay, and I before I forget, there are slides specially meant for all of you. Take photos. So photo session will come at the last, where you need to take photo, screenshot, and remember whatever I have said. So please wait for it, and we will be going to photo session later. Okay, I should have remembrance with all of you. So to conclude, Mossad skill in when there is anion gap is high, if both are matching, we have pure anion gap metabolic acidosis. If the fall in F as compared to rise in anion gap, if the fall in bicarbonate is small, if fall in bicarbonate is small on the left side, then it is hidden bicarbonate gain, and that happens in hidden metabolic alkalosis. Towards the right side, if the fall in bicarbonate is greater, that means there is hidden bicarbonate loss, and therefore there is additional normal anion gap metabolic acidosis. Now, before I go to further question, I would like to just ask that, is it clear to all of you Mossad skill, or should I repeat? Loudly, please reply. Is Mossad skill clear to all of you, or should I reply? Delay
Yes,
means
sir.
I have to reply. See, delay means I have to reply. Okay. I will just repeat that in high anion gap metabolic acidosis, compare rising anion gap with fall in bicarbonate. If both are equal, there is no third disorder. If both are equal, there is no additional disorder. Rise in anion gap and fall in bicarbonate are matching. But as compared to rising anion gap, if the fall in bicarbonate is lesser, there is hidden bicarbonate gain, and therefore it is suggestive of hidden metabolic alkalosis. So if rising anion gap is 12, but fall in bicarbonate is 4, if rising anion gap is 15, but fall in bicarbonate is 5, that means there is hidden metabolic alkalosis. If both are 12, there is no disorder. And likewise, if rising anion gap is 12, but fall in bicarbonate is 20, if rising anion gap is 12, but fall in bicarbonate is more, say 20, which is more, it is suggestive of hidden bicarbonate loss, and that is suggestive of hidden normal anion gap metabolic acidosis. So this is the final slide where we compare if both are equal, pure high anion gap metabolic acidosis. If the fall in bicarbonate is smaller, that means there is hidden metabolic alkalosis. If the fall in bicarbonate is greater, it is normal anion gap metabolic acidosis. So Mossad skill is comparing rise in anion gap with fall in bicarbonate. And with this, let us go ahead. And now comes the Mossad practice. Okay. Now we have Mossad practice, because what I have discussed, are your concept clear or not? That will be clear from this discussion. So this is a patient with high anion gap metabolic acidosis, where we are comparing rise in anion gap with fall in bicarbonate, and therefore we have to find out that whether there is additional disorder present or not, and if present, then what is the disorder. So now I request all of you to join me. Rise in anion gap is 20, but fall in bicarbonate is 10.
Metabolic
alkalosis.
Yes, there is the fall in bicarbonate is small, so there is hidden bicarbonate, and hidden bicarbonate is metabolic alkalosis. So rise in anion gap is 10, but fall in bicarbonate is 18.
Normal anion gap.
Associate normal anion gap metabolic
Yes. So as compared to rise in anion gap, greater fall in bicarbonate suggests that there is hidden normal anion gap metabolic acidosis. Rise is 15, fall is 15.
Only high anion gap metabolic acidosis.
Yes, no additional disorder. Rise in anion gap is 12, but fall in bicarbonate is 19.
Normal anion gap.
Normal anion gap metabolic
Yes, so greater fall in bicarbonate is suggestive of additional normal anion gap metabolic acidosis. Rise in anion gap is 19, but fall in
Metabolic
bicarbonate is 4. So,
Metabolic alkalosis.
yeah, so it's metabolic alkalosis. So I have reached to the conclusion that I could convey massage skill very properly to all of you, because you could really reply without slightest hesitation, including those friends of mine who are on YouTube. So now with this, we will conclude that suspect acid-base disorder, diagnose primary disorder, and after primary disorder, for mixed disorder, check direction of changes, calculate and calculate expected compensation and compare with actual value. Then comes the CID skill, and for diagnosing triple disorder comes the massage skill. CID skill is check anion gap, and massage skill is compare rise in anion gap with fall in bicarbonate. And now truly I promise that this is the last questionnaire which I have, last discussion, and I'm confident that all of you are now smart, ready, and have learned the things very well. So this question answer, last problem solving will be a really fun. Okay, now pH is 7.48. So now please reply, what is the problem? pH is 7.48.
Alkalosis.
Step by step, don't answer ahead of my question. Okay, so it is alkalosis. Now next question.
Metabolic alkalosis.
Yes, it's metabolic alkalosis, and therefore I have spent 1 hour without gain, because if it would have been metabolic alkalosis, bicarbonate should have increased, but bicarbonate is 20. So is it metabolic alkalosis?
No.
No. So it is alkalosis, that is certain. But what kind of alkalosis it is? Yes, PCO2 is 29, and therefore our diagnosis is?
Respiratory.
It's very simple. You have CID skill, massage skill, and you have primary skill. So first you should have primary skill, and that is to diagnose primary disorder. So alkalosis is what?
Respiratory alkalosis.
Yes, respiratory alkalosis, because there is decrease in PCO2. Okay. Now check direction of changes. That's magic formula.
Yeah, both same direction.
Same direction. Okay, direction are same. Okay. Now after that, we have respiratory alkalosis, and a patient has abdominal pain, and this event has occurred acutely, and therefore for compensation we will use formula
0.2.
out of 2 and 4. We will use formula 2. Okay, now if we use formula 2 for reduction in PCO2, the bicarbonate will reduce. So how much will be the reduction in bicarbonate?
24 minus 2, 22.
Yes. So yes. So 0.2 into 11 is equal to 2.2 will be the fall in bicarbonate, and therefore what will be the expected value of bicarbonate?
22.
22.8.
Precisely
21.8.
21. Yes, precisely speaking, it is 21.8. So expected bicarbonate is 21.8, and actual bicarbonate is how much? 20. So little lesser, and when bicarbonate is little lesser, it is suggestive. I mean, roughly it is suggestive of what? Not diagnostic.
Metabolic acidosis.
Yes, so we are suspecting that it could be metabolic acidosis. So now what next? What next?
Anion gap.
Yes. So now comes the anion gap. Okay. And anion gap is sodium minus total of chloride plus bicarbonate. So how much is the anion gap here?
27.
Yes. Anion gap is 27, which is totally normal. Okay. Anion gap is 27, which is totally normal.
No, sir. High anion gap.
That means my diagnosis is that at the end of my webinar, everybody is alert.
No, sir. It's
So
high
my
anion.
diagnosis is that everybody is alert. Anion gap is 27, suggestive of high anion gap. 27 anion gap is not normal. But I was just testing whether you are awake or you are not awake. But then all of you are alert and with me. Okay, so our CID skill says that the anion gap is high, patient has high anion gap metabolic acidosis. Now, anything else?
Change in anion. Mossad.
Yes, so Mossad, compare rise in anion
Mossad
gap
still
with
here.
fall in bicarbonate. So what is the rise in anion gap here?
15.
15.
27 minus 12, 15.
And how much is the fall in bicarbonate?
4.
Divided by 4.
Yes, so we have rise in
Four.
anion gap is 15,
3.6.
but fall in bicarbonate is just for suggestive of what?
Hidden metabolic alkaline.
Yes,
Hidden
it is
metabolic
hidden
alkaline.
metabolic alkalosis.
Alkalosis.
And therefore, I am happy to conclude that patient has alkalosis, it says respiratory
Respiratory
alkalosis
acidosis.
with high
Respiratory
anion gap
alkalosis.
metabolic acidosis
Acidosis.
with metabolic alkalosis. And therefore, what all of you have diagnosed is triple disorder. It's a triple disorder. And therefore, from my PC, I am sending lot of bouquets, flowers, and congratulations to everyone who are in YouTube, who are with me on Zoom platform, and congratulate all of you for diagnosing triple disorder, because it's a great achievement on your end. I'm so happy that you could come to diagnosis of triple disorder so easily. But remember, this is the beginning. Now you will able to diagnose mixed disorder, triple disorder easily in day-to-day interpretation of ABG. I hope that we will end here because it was a long session. I would like to thank all of you, but I have question for all of you. Whether learning ABG is difficult or easy? Loudly.
Easy, sir.
Easy.
Easy.
Easy now.
I had said that I am going to repeat the question. And now we have take-home photos. Okay, because that you have to carry with you. But before that, I would like to thank all friends of mine across the country for supporting this book, Practical Guidelines on Fluid Therapy, with a huge sale. And I also would like to inform you about one of the important mission of my life, and that is kidneyeducation.com, which is mission to prevent and care kidney disease. This is the website available in 39 languages. It's proud of India because it received world record for ebook in highest number of languages. You will be happy to learn that this kidneyeducation.com website provides 200-page kidney book free in 27 international languages and 12 Indian languages, including even Tamil. See, Tamil language book is available, free to download. And with support of all friends, up till now, our website received more than 9 crore hit. But don't give credit to me, because this is a teamwork of more than 100 nephrologists across the world. We have leaders like Dr. Rumuzi, who was president of International Society of Nephrology. We have Dr. Garcia, who was a president of International Federation of Kidney Foundation, who prepared Spanish language. And we have representation from across the world. And very, very important part of story is that this educational efforts, which took almost 16 years, is free from any kind of sponsorship of any pharmaceuticals. There is no, besides 9 million hits, there are no advertisement, and we don't take any financial support, aids, or donation for this activity. But we request all of you to spread information about this website to all your friends, kidney patient to whom you know, and try to spread a word about this kidneyeducation.com website. We are blessed. We are blessed because we have blessings of pious, respected, honorable president like Abdul Kalam sir. With this, again, back to my promise, and that is take home photos for all of you. Last part of today's discussion. And see, if you want to get this book on WhatsApp free, then this is the number. You can get a book in any of the language out of 39 languages free from this website. Okay. And now start taking photographs. For diagnosed primary disorder, this is what is there. So with this, I will again convey my heartiest thanks to Dr. Edward sir and the team who gave me this wonderful opportunity. Next slide. And this was truly a great experience because in classroom we can teach this subject very easily, but teaching on webinar, keeping my friends with me, to whom I cannot see, is something which is challenging, but till end, all of you were expert. I'm changing the slide. This slide will remind you everything for compensation in metabolic acidosis, 1.5 times bicarbonate plus 8 in metabolic alkalosis. Rise in PCO2 is equal to 0.6 into bicarbonate rise. Respiratory acidosis, remember 1.4. In respiratory alkalosis, remember 2.4. And last but not least is the massage skill only in patient with high anion gap metabolic acidosis, where if both are matching, it is a pure disorder. If fall in bicarbonate is lesser, hidden metabolic alkalosis. If fall in bicarbonate is greater, additional hidden normal anion gap metabolic acidosis. I would conclude with regret to say that I was so much engorged and I was so much touched with all of you that I couldn't see my timer. I have exceeded my time of discussion, but then here I cannot cut down either CID skill or massage skill. And with this, I again thank Dr. Edward sir and his team for giving me this wonderful opportunity to teach. Thank you very much.
Thank you, sir. Thank you for this wonderful lecture. We are lucky to have you on our platform, sir. We are blessed to have you on our platform. Over to Gomadi. Is there any questions? You can.
Oh my God, that was such a mesmerizing class. I got lost myself and I've been taking notes. So it's a beautiful class. Thank you so much, sir. We're truly grateful. Just brushing through the questions. We have how do we diagnose whether it's an acute or chronic metabolic or respiratory acidosis?
Now, see, all of you are always taking care of this patient. So clinical part is something which is very, very important, clinical scenario. And second thing that even we need to look at the pH, because when there is acute change, the change in pH will be smaller because compensation has not occurred. Compensation takes time. While when you look at the chronic disorder, say respiratory alkalosis with PCO2 of say just 15 or so, but then bicarbonate may not be may not be that. I mean, bicarbonate will be low, but pH may not have changed substantially. Say we are seeing respiratory acidosis with 110 PCO2, but pH is just 7.3 or something like that. And against that, if you look at the bicarbonate is say somewhere around 40, 45. So if we look at if we diagnose, then look at number 1, pH, and number 2, bicarbonate. If bicarbonate has changed substantially and pH is towards normal, that means it's a chronic disease. If the change in bicarbonate is small and change in pH is minor, that means we are dealing with the acute disorder. Sometime in future, we will have a discussion where we will again discuss many of the part which I have excluded, including whether the validity of ABG report is proper or not, how exactly we calculate change in pH, arterial versus venous ABG reports, and many more things, because already we have spend 30 minutes more. So,
Okay. Gomadi, madam, please note down the
Yes,
question.
sir.
We will forward the
Yes,
question,
yes, I have.
sir, and get the
Yes,
answer, and we will publish it in the Facebook page, the question and
Yes,
answer.
sir.
Thank
Yes,
you so much, sir, for
exactly.
sparing your valuable time, sir. Thank you. Thank you,
our
sir.
pleasure was on either side.
Okay, sir.
And again, before leaving, March will be World Kidney Day, and I will send WhatsApp message informing about our kidney education website, and I request that whole team will support this educational information to spread the information about awareness and prevention of kidney disease. I hope that now I have a larger team with me to spread this information.
Definitely, sir. We are with you, sir. With that, we will move on to the next session. Postgraduates, don't feel bad. Your questions will be forwarded to sir, and I will get the answers, and I will post the answers in the Facebook page. Is it okay, sir, with you, sir?
Perfect.
Okay.
We will keep in touch.
Thank you so much, sir. Gomadi, madam, we will move on to the next session.
Thank you so much, sir. Our next session will be a video presentation by Dr. Praveen, who's a consultant anesthesiologist at Royal Care Speciality Hospital, Coimbatore. And he will be giving us a video presentation of anesthetic challenges in a foreign body airway. Over to you, Dr. Praveen, sir.
Thank you for the introduction, ma'am. Hi, good afternoon, one and all. Myself, Dr. Praveen Kumar, working as a consultant in Royal Care Speciality Hospital, Coimbatore. I think Sanjay sir has drained all your battery level. So I want everybody to quickly recharge your brain so that we will concentrate on this new topic. Okay. So is everybody here? Okay. So the topic for discussion is something related with the airway. When it comes to airway, everybody is quite excited. At the same time, when it comes to difficult airway, we are also worried how to secure the airway without putting the patient in problem. So the title for discussion today is Challenges in Retrieval of Airway Foreign Body. So the foreign body retrieval, the job is done by both the ENT people and nowadays pulmonology people also doing the job with advanced equipments. So with what complaints these patients come to us? So it is usually 3 C's: choking, coughing, and consolidation. When the patient aspirates a foreign body and lands up in a respiratory distress, when there is no inflow or outflow of gas across the obstruction, the patient lands up in choking and it creates a fear of death. It is an immediate presentation. We have to treat it aggressively. And the second one is coughing. If the patient is not able to cough out the foreign body because of hypoxia, patient becomes tired and the foreign body gets adapted to the body and the body will try to adjust the obstruction and will start adapting the situation, and over a period of time the patient becomes asymptomatic and patient may present with mild coughing. And the third stage is consolidation. Over a period of time there may be secondary bacterial infection and the patient may present with the collapse, consolidation with the fever, chills, and the respiratory distress. So these are the 3 main presentation how the patient will come to us. It's called 3 C's: choking, coughing, and consolidation. So what are the patterns of presentation? When the patient complains of foreign body aspiration, so how this behaves? So the here I stands for ingress of air and E stands for egress of air. That is the airflow during inspiration and airflow during expiration. So we have 4 types of presentation. The first one is called bypass valve, where the obstruction is partial. There will be a possibility of airway flow both during inspiration and expiration, and patient may sustain this obstruction without any difficulty. So there is both inflow and outflow of gas across the obstruction. This is called bypass valve. And the second is stop valve, where the obstruction is totally occluding the flow of gas across the site. So there won't be any movement of gases across the obstruction, and the lung will slowly go for absorption atelectasis followed by collapse consolidation. So there won't be any movement of gas across the obstruction both during inspiration and expiration. And the third one is check valve. So during check valve, there will be flow of gas during inspiration, but during expiration, the airway collapses and there won't be any letting out of gas across the obstruction, the lung will expand and goes for emphysematous changes. So there will be flow of gas during inspiration, but there won't be any flow of gas during expiration. The lung expands going for emphysema. And the last one is ball valve mechanism. It is opposite to check valve. There won't be flow of gas during inspiration, but there will be a flow of gas during expiration. So again, the lung goes for collapse consolidation. So these are the usual four ways of presentation. Bypass valve, the patient will be mostly asymptomatic because there is flow of gas both during inspiration and expiration. On stop valve, the patient will be in acute respiratory distress because there is no inflow and outflow. The patient may come with choking. And check valve and ball valve, it happens over a period of time. So what is the ultimate problem for this patient? So there is no proper oxygenation, there is no proper ventilation. So how are we going to help them? So we are going to help them by means of these four modes of ventilation. The first one is called apneic oxygenation. The second is called spontaneous ventilation. And third is low frequency jet ventilation. And the fourth one is high frequency jet ventilation. So let us see the airway challenges when we use a flexible bronchoscopy to remove the foreign body or rigid bronchoscopy to remove the foreign body. So what are the anesthesia challenges? So you have to do a first clinical examination from head to foot. How is the consciousness of the patient with respect to brain, whether the patient is drowsy or not conscious because of hypoxia? And comes to neck, how is the airway, how is the C-spine position? When it comes to respiration, you have to see what is the saturation, how is the oxygen status of the patient. When it's come to abdomen, you see what is the nutritional status, when was the last feed taken, and when was the last urine passed. And when you come to periphery, you see for IV access. So these are the basic clinical examination you have to do and keep it in your mind. An investigation, if the patient is in very distressed, at least chest X-ray to see where is the site of obstruction. And optimization, if the condition is chronic, then you can give you antibiotics or bronchodilators and I can hydrate the patient. If the patient is in stress, then immediately you have to take the patient to the OT. So what is the anesthesia plan? We have to discuss the plan with the surgeon or the pulmonologist. So how are we going to take out the foreign body, whether using flexible bronchoscopy or rigid bronchoscopy, and what is the backup plan if suppose we are not able to follow the primary plan, and what are the anticipated complications like pneumothorax or pneumomediastinum or post-op elective ventilation for a few more hours or a day. So these things has to be discussed with the parent, and you have to let them know what is the series of the condition so that it helps in better plan management. So let us see the plans. This is followed both in flexible bronchoscopy and rigid bronchoscopy. So this is a dialogue usually our senior says whenever you go for a anesthesia, when you go for a case of foreign body bronchus, don't burn the bridge. Don't try to burn the bridge because our patient is already in a common state. Suppose if there is an insult and a loss of airway, the patient may die on table. So the flexible bronchoscopy helps in this three way. Even though the plan is a rigid bronchoscopy, we may perform flexible bronchoscopy to see. This is called down look to see what is the status of the foreign body, whether it's organic or inorganic, whether it's space around the foreign body. And we can do a topicalization by the same way when you do a flexible bronchoscopy with local anesthetics. And sometimes it is feasible, you can do the foreign body removal with the flexible bronchoscopy alone. So for flexible bronchoscopy, we use a second generation supraphletic airway device like iGel with the tracheal mount and a laparoscopic port cap to minimize the leak around the fiber optic scope. So this is a chart of a patient, 8 months old baby, came with complete foreign body aspiration respiratory distress. So it looks after that. Let us see this video, then we will come to the chart. So what are the things that is in the chart? So everybody watch the video carefully. So we can see the glottic aperture as the scope passes beyond the vocal cord. Sorry. Is my video playing?
No, sir, not it.
It's on pause, I think. Not yet. I think it's on pause.
So what's the problem? Praveen sir, please continue.
Sorry, it's getting
Right.
stuck.
Guru Sanjay, what's the problem?
So video play all sir orange.
Okay. Okay.
Have you clicked on the play button?
I think so. Yes, first it was playing initially.
Go back to the slide and okay. It's loading slowly.
It's a HD record. That's why it is not streaming easily. High definition.
Praveen sir, if this video is there in your laptop, you can directly play it.
Okay, sir. Okay.
You can stop sharing this one, sir.
I'll take my video once.
Okay, fine.
Now it's visible, sir? Now it is visible?
It's not moving, sir.
But here video play is playing.
Sir, you have to stop this PPT, stop sharing. Then you have to share your video again, sir. I stopped the PPT. Now you can share your video again.
Praveen sir, sometimes what happens, they hide high quality video recording may not be compatible with the PowerPoint.
PowerPoint. Now it's visible, sir?
You are not shared your screen.
No, you are in screen, full screen.
Okay.
You play the video, then share the screen.
Okay, understood.
It's okay. This is also a learning curve for us. Relax.
I think now it's visible, I think.
Yes.
Yes, sir, it has come.
Awesome. Yeah. Now it is excellent.
So this is the glottic aperture. When the fiber scope moves into the, you can see the movement of the arytenoids when the patient is breathing spontaneously with minimal movement. So the scope is negotiated through the vocal cord. You can see the adduction of the vocal cord. Just at the inlet of the right main bronchus. So they are trying to put the snare across the side of the foreign body. They're trying to pass the foreign body with the snare, with the basket example. So you can see oozing of blood across from the wall of the bronchus. They are now opening the snare. They are trying to catch the foreign body with the basket. But it comes in piecemeal. So it is not, we are not able to take the mass with the basket. Now they're trying to take it off with the cryoprobe. So there is, you can see the freezing condensation near the tip of the cryoprobe. Yes, they're able to get the foreign body. The most critical part is now. So you can see the freezing of the probe tip. They're able to see they lost the vision during the retrievation. So they don't know what is going on. So when they adjust the probe and see, there is slippage of foreign body and the tip got stuck to the wall. Now there is unfreezing. The probe tip gets freed from the tracheal mucosa. Immediately they are taken off. Now the foreign body is left in the main trachea, central airway, where the patient will not be able to breathe or exhale. So we have to do everything very quickly. Again, they are going with the basket. So we can see the foreign body just in the main trachea. They're putting the basket all around. They're catching it. Now it's been removed. So they're getting the foreign body out of the airway through the igel. So you can see the internal rims of the igel when they take it out. Now the foreign body has been taken out. Again, they're putting the scope back into the airway to see what are the changes the foreign body has created. You can see the adduction of the vocal cord with the arytenoid complexes. They're again going down. See, this is the area, right main bronchus origin, where the foreign body is stuck. You can see the upper lobe take off here, and the lower lobe and middle lobe over the right side. So this is the video of the foreign body removal using a flexibronchoscopy. Just I'm stopping my screen share and going back to PowerPoint. So now we'll see this chart once again. So now I will split this chart into 5 parts. So induction and maintenance, how I did the induction, maintenance, fluid balance, circulation, monitoring, oxygen filtration, everything. So with induction, I used both T1 inhalation induction. As a child is drowsy, you can see the baseline saturation of 80 here. So you can see the saturation of 80 when the patient comes to the hospital. So the patient was very drowsy. So I used the steel technique of induction to start with CO of 0.6%. So slowly increase this induction agent to 8%. Then I used the ketamine and fentanyl for pain relief. When they try to put the rigid, I do not know when we started the procedure, because look down scope we have used. With the same scope, we have removed the foreign body. There is a change of plan. And I used minimal dose of thiopentone to blend the hemorrhagic response. And hydrocortisone was used, and dexamethasone was used for to minimize inflammatory edema. So everything, the dose was like fixed as 1/4 of the loading dose. So everything, the patient weight was 10 kg. So ketamine was taken as 0.5, fentanyl was 0.5, thiopentone was 0.5. Everything was taken 1/4 of the induction dose, and the induction was done. The total duration of the procedure was 1 hour. So you can see the heart rate when they try to pass the scope through the airway, and when they put the basket around the airway going up to 180, and you can see the saturation from 80 it has gone to 66 when they missed the foreign body in the central airway. So initially I used a two-size sigil for look-down scope. Once they extubated, we tried ventilating the patient with the igel for some time, but the ventilation was not satisfactory. So with the scoline and thiopentone loading dose, we have intubated the patient and ventilated the patient for 12 hours. Then we extubated. So the total fluid given was 40 ml plus 40 ml during the procedure time. So since it is spontaneous breathing and with a lot of airway leakage around the catheter mount side, we will not be able to monitor the carbon dioxide, and the respiratory rate is around 30. So the main problem with the foreign body retrieval from the main bronchus is, suppose if the foreign body slips into the central airway, then becomes a tricky situation. We should not become panic, and we should not make the surgeon be panic, because the time available is very less. We both should involve the procedure and try to get the foreign body out of the central airway, or try to push back the airway again, foreign body again the same airway, so that we get at least 1 lung to ventilate. So this is a short video how we put the rigid bronchoscopy. This video is done in a adult patient. So an igel has been placed to topicalize the airway and for also look down scopy. And a gentle laryngoscopy is done to clear the airway of secretion before topicalization or the laryngeal aperture. You can see the patient coughing, minimal patient coughing. This is not very exaggerated, this is a very minimal coughing. Once topicalization of the laryngeal aperture is done, I hold the mask and ventilate the patient. Assist the ventilation for 2 minutes. You can see the bag movement and the chest rise. Once the adequate time has been over, I'm asking the pulmonologist to put the scope into the larynx. At minimal type of induction it was given. You can watch here. They put the scope across the glottic and they twist it to enter into the laryngeal aperture. Then the circuit is attached to assist the ventilation. So always in foreign body, this is a baseline. Don't burn the bridge. Whatever patient has given you, try to maintain the airway with it. If you don't have high sophisticated equipments like jet ventilator. So again, it's a 1-year-old baby. While playing, suddenly it becomes drowsy. And within a matter of minutes, the patient becomes drowsy and sinuses. And the patient has been got to the casualty. When the patient reaches the casualty from home to the house, the distance was around 100 kilometers. The patient almost had an impending cardiac arrest. The patient, without any investigation or anything, we have taken the patient to the pulmonology suite. Then we did an immediate rigid bronchoscopy. You can see the rigid bronchoscopy is got to the subglottic level. You can see a foreign body sitting in the main airway, central airway. It's a ground nut. And with alligator forceps, they're trying to pull the foreign body into the rigid bronchoscopy. You can see a passive expression, exhaust of secretions when they take out the foreign body into the central airway. You can see the secretions coming out. The patient started expiring the gas out. So this way, this foreign body was removed. So what are the anesthesia challenges with respect to rigid bronchoscopy? It is applicable both to pediatric group and adult group. So system wise, there will be a lot of hemodynamic fluctuation. As I already shown you, the heart rate may go from 100 to 180 and BP may fall because of the high induction dose and deep plane of anesthesia maintained. And there will be ST changes. So you have to keep all your vasopressors and beta blockers to get the hemodynamics under control. And we usually use TIVA with Propofol and Dexmed. And compared to respiration, you need a high flow oxygen to compensate for the leak. The flow may go from 10 liter to 15 liter per minute, and minimal coughing is allowed. If the patient coughs vigorously, the scope may land up in mediastinum and may cause a pneumomediastinum. So keep your plane adequate so the coughing is minimal or there is absolutely no coughing. And before extubation, always put a direct laryngoscopy, see for any vocal cord or laryngeal aperture edema. And before pushing the patient for rigid bronchoscopy, we want the central incisor to the anterior commissure to the anterior tracheal wall to be in the same line. So always load C-spine issues before putting the patient for rigid bronchoscopy. And awareness is already accepted. We will not be able to titrate our induction dose. It depends upon the hemodynamics. And if you have a bispectral entry monitoring, we can do depth of anesthesia monitoring and prevent awareness. And there will be if you always put a tooth guard, because there is always a chance when the scope lands up in the upper central inside, there's a breakage, again it may fall into the airway. And a rigid bronchoscopy is a painful procedure with high sympathetic stage, so always be a proper topicalization before or during rigid bronchoscopy. And patient and the interventionist wall strap may land up on the patient's eye. Always pad the patient eye with the dressing and do a end up eye assessment if you plan to extubate the patient on table. So these are the minimal anesthesia challenges with respect to each system, how to plan a rigid bronchoscopy for this kind of patients. So coming to the few points about other modes of ventilation other than spontaneous assisted ventilation, we have jet ventilator, which may be of Sanders type or managed, or we can have an automated jet ventilator where you can control the inspirate and expirate time with the driving pressure. So this is a Sanders jet ventilator module, how the jet has been, airflow of gas has been into the bronchoscope through the trachea, and you have to give adequate time for the lung to collapse so that you can deliver the next jet, because there is a chance of autopip and barotrauma to the lung. So I usually follow ACE protocol whenever I go for rigid bronchoscopy. You always anticipate things. When you anticipate, you always try to communicate, but communicate in a gentle way. Your expression is should be very gentle, because both the people are managing the airway. Like I said, in the foreign body, the right main bronchus foreign body got missed into the main trachea. If both of them become panic, then both of them will lose the airway. So one of them has to give the chance to the other to get the condition into the control. So even the patient saturation goes to 66, yes, we will be able to intubate and push the foreign body into one of the main bronchus. There is a backup plan. So give time for the other people to do the job with comfort. Thank you. This is a short video I have made with the last 2-3 months cases. It's open for discussion, sir.
Okay, sir. Thank you for excellent videos and your good presentations. Dr. Gomati, madam, is there any questions?
Yes. Yes, so we have one question. I think all our viewers are still embedded with the ABG. We have one question from Dr. Janelle McLean. She's asking us, what is the position of the head of the patient while passing the rigid bronchoscopy?
It's in Rose question.
What would be the position of the head?
Position of the head, the C-spine has to be flexed over the thorax, and the neck atlantoaxial joint has to be extended so that you get the oropharyngeal laryngeal axis in a straight line. So the scope is not a flexible structure like our ET tube. It is a rigid structure, straight line. So the airway passage also should be in a straight line.
In pediatric cases, what will you do, sir? Pediatric cases with large head, will you bring it to the...
No, we minimally keep a shoulder support just for the elevation of the shoulder alone. That's all.
Okay.
We keep it 2 slant backs on either side of the skull to prevent the rotation of the head, and a minimal shoulder roll to support the thorax. That's all for pediatric cases.
Okay. Is there any other question, Gomati madam?
No other questions.
There is one other question from Ahmed Mohammed.
Yeah, what techniques is more appropriate among the 4 mentioned? What technique is more appropriate?
Whichever you got trained very well, that will be a simple answer, because all 4 cannot be, one cannot be expert in all 4 techniques. Whichever technique you learn from your seniors and teachers, you follow the same technique, but you always have a backup plan. If that fails, what is the next? So I always follow spontaneous ventilation. If the patient is not, we are not able to ventilate, then we have jet ventilator. We can use of that. But if you use jet ventilator, if you are not able to ventilate the jet ventilation because of rise airway pressure, then you need a backup plan. That is, so you master the spontaneous ventilation, spontaneous assisted ventilation. Then you can use some of the any other technique as secondary, appointed plan, second technique. High frequency, if the surgeons want a complete motionless field, then you can use a high frequency jet ventilation, but the cost is a constraint. It will not be available in all places.
So another question is there, what pressure you will set for the jet ventilation, pediatrics and adult?
Jet ventilation, automatic jet ventilator, we can set from 15 PSI to 50 PSI, 15 to 50, 15 PSI to 50 PSI. But the end point is the airway pressure. If you have a tool to monitor the airway pressure, you try to keep your mean airway pressure less than 30, because you can set your peak inspiratory pressure, you can set your peak. You try to monitor your mean airway pressure, try to keep your mean airway pressure less than 30. That can be achieved only if you let out the gas from the lung by increasing the expiratory time or decreasing the inspiratory time. So if you decrease the inspiratory time, again your peak inspiratory pressure is going to rise, cause barotrauma. Again, you have to decrease the driving pressure. So it's a continuous process. There is no fixed setting. You can start with one setting, like I say, 15 PSI of driving pressure, respiratory inspiratory expiratory ratio of 1:2. Depending upon the mechanics of the lung, you can change the settings. The ultimate aim is to keep the mean airway pressure less than 30. If you have a transcutaneous carbon dioxide monitoring, you can adjust the setting according to the PCO. But PCO transcutaneous monitoring helps during the static phase of the procedure. During dynamic phase, that is during induction, the changes will not be very immediate in the blood, so it may take some time.
Yes, sir. Rightly said. It depends upon the airway resistance and compliance. You have to adjust the pressure. The last question, sir, from Kribaran, our past State Secretary of ISA. Kribaran, welcome you, sir. What do you think about paralyzing the patient? Any advice? Will you advise?
Paralyzing is the last resort. As far as concerned me, the system is totally out of control, we have only last chance, then you paralyze, give the maximum comfort for the surgeons to get the foreign body. If they're not able to get the foreign body at the last chance with the paralyzing, then you are going to lose the patient. But we can do paralyzing, like if you have a jet ventilator, you can paralyze, you can get the airway in control. The foreign body in one of the main bronchus, you can paralyze and get into the control. The patient, foreign body is central airway, main trachea, and it's difficult to remove chronic foreign body vegetative, then try to keep the airway protected. You go see how is the status, whether it is easily removable or not, then you paralyze accordingly.
Thank you so much, sir. Gomati madam, we can finish it.
Yes, that brings us, I think that is the end of questions here, sir. We can move on to the quiz section, sir.
Madam, quiz, time is over. We will move on to next week.
Okay.
Students, we can face the quiz
sir.
today in the WhatsApp. So we will skip the quiz program. Thank you so much.
Thank you, Edward sir.
Edward sir, Edward sir, it's fine, sir.
Thank you so much.
Edward sir.
Yes.
Edward sir, Shilpa here.
Shilpa. Thank you, sir, Shilpa.
Yeah.
Nice coordination.
No, we can start, sir. We can start. It's okay, sir.
No,
Quiz.
Okay. So then I will share the. But pages, will they remain?
185 people are there.
Okay. So we move on to the quiz corner. So my first question is, an acute increase in PaCO2 of 10 mm of mercury will result in a decrease in pH. Sanjay has discussed PaCO2 relation to the bicarbonate, but here I am asking the PaCO2 relation to the pH. So what could be the answer? 0.01, 0.02, 0.04 or 0.08? Hold please. Still they are answering. Okay. So the answer they are given is 0.01. So we will see the answer. So it is 0.08. So the respiratory acidosis is present when PCO2 is greater than 44, you know. So the respiratory acidosis is caused by decreased elimination of carbon dioxide by the lungs. It may be due to the hyperventilation, or maybe it may be due to the increased production of the carbon dioxide by metabolic action. In acute increase in PaCO2, remember it is acute respiratory acidosis. For every rise in PaCO2 of 10 mm, the pH will be 0.08. So the acidosis of arterial blood, what will be the compensation? It will stimulate the carotid bodies, and the acidosis of the cerebral CSF will stimulate directly the chemoreceptors in the medulla, and it increases the respiration. Your volatile anesthetics will attenuate only the carotid body and aortic body mediated ventilatory response. It does not affect the medullary chemoreceptors mediated increase in respiratory rate. So moving to the second questions. That is, the following blood gases would best be explained by which disorder? pH 7.18, PaCO2 25, and your bicarbonate 11. So it could be a aspirin overdose or nasogastric suction or chloride wasting diarrhea or a hyperaldosteronism. Hold please. Hold please. You know it is acidosis. So what could be? So everybody know the answer. Okay. So most of them answer correctly. So it is aspirin overdosage. The acid-base disorder described above is the metabolic acidosis with compensatory respiratory alkalosis. If the anion gap here it is not mentioned, if you calculate it will be above 22 milliequivalent. The only item listed above that causes the metabolic acidosis is aspirin. Other options are causes only metabolic alkalosis. So moving on to the third question. A venous blood sample from which of the following sites would correlate most reliable with PaO2 and arterial PaO2 and arterial PCO2? That is jugular vein, subclavian vein, anterior cubital vein, or vein on the posterior surface of the warmed hand. So here is the poll. So which venous blood will resemble like the arterial blood sample if you take the samples in the above site? So the answer is in the vein on the posterior surface of the hand, because when arterial sampling is not possible, you can go for arterialized venous blood to estimate the ABG. For that, you can collect the blood samples from the vein on the back of the hand, because the oxygen content in the blood is almost approximates the oxygen content of the arterial sample, because the oxygen extraction ratio is less in the posterior surface of the hand. So the next question is, a decrease in pH of 0.1 unit will result in, so there is always a correlation between the pH and potassium. So whether it increase the potassium or decrease the potassium. First option is a decrease in serum potassium. Second option is decrease in potassium of 1 milliequivalent, increase in potassium of 1 milliequivalent, and fourth option is an increase in potassium of 2 milliequivalent. Poll, please. At least you must know whether it will increase or decrease the potassium. So your answer is correct. So it increased the potassium up to 1 milliequivalent. So you know the cardiac arrhythmias are commonly associated with acid-base abnormalities. So the etiology of the dysarrhythmia is related to the acidosis that affect the pH in the myocardial potassium hemostasis. So change in pH causes potassium to either shift into the cell or out of the cell. That's why we are in hyperkalemia. We are giving bicarbonate to shift the potassium into the cell. So the rise in potassium for a reduction in pH is somewhat variable, but will definitely result in increase. So the range spans from 0.2 to 1.7 milliequivalent per liter. So the answer is 1 milliequivalent per liter. So the fifth question is, a 17-year-old type 1 diabetic with history of renal failure is in the preoperative holding area awaiting for an operation of acute appendicitis. The arterial blood gases are obtained with the following results. That is PaO2 of 88, PCO2 of 32, pH of 7.2, and bicarbonate 12, and chloride 115, sodium 138, glucose 251. The most likely cause for this patient's acidosis is whether it is due to renal tubular acidosis, lactic acidosis, diabetic ketoacidosis, or aspirin overdosage. Poll, please. So here you have to calculate what Sanjay said, anion gap. You calculate the anion gap and see what could be the acidosis. Thank you. It's not diabetic acidosis because here the anion gap is only 11. So the calculating the anion gap helpful in determining the cause for the metabolic acidosis. So how to calculate anion gap? It is difference between cation and anion, that is sodium minus chloride plus bicarbonate, and is normally 10 to 12. In this case, the anion gap is 11. So it is a normal anion gap. So you have to think of the causes of metabolic acidosis with normal anion gap. So the high anion gap metabolic acidosis is lactic acidosis, ketoacidosis, acute and chronic renal failure, and toxins. And non-ion gap metabolic acidosis is renal tubular acidosis, like in this case. And your rapid saline infusion and your gastrointestinal loss of bicarbonate and drug-induced hyperkalemia and your acid loads as in the case of diabetes. So your vomiting and nasogastric drainage are some of the many causes of metabolic alkalosis. So we will move on to the sixth question. So a 55-year-old man with polycystic liver disease undergoes 8-hour right hepatectomy. The patient receives 5 units of packed red cells, albumin, and 6 liters of normal saline. The patient is extubated and taken to a post anesthesia care unit where ABG was done. So the ABG was PaO2 135, PCO2 44, pH 7.17, waste deficit -11, bicarbonate 12, saturation 97, chloride 19, and sodium 145, and potassium 5.6. The most likely cause for this acidosis is lactic acid, use of normal saline, diabetic ketoacidosis, polyethylene glycol from the bowel preparation. Hold please. So almost everybody is answering the correct. So the patient had received 6 liters of normal saline. Yes. So most of them answer correctly. So we'll see the answer. So it is use of normal saline. So this patient has a metabolic acidosis. Recall the anion gap, which is 10 to 12 is the normal. In this case, the anion gap is 14. So which is slightly above the normal anion gap range. In looking at this case, the acidosis is quite profound and would most likely to relate to the rapid infusion of the normal saline. The lactic acid, ketoacidosis, and ethylene glycol produce high anion gap metabolic acidosis. So we will move on to the 7th question. So which one of the following statement is true regarding the anion gap? So most of the questions are based on anion gap. So anion gap of 12 milliequivalent per liter is considered abnormal. So diabetic ketoacidosis is associated with low anion gap. Metabolic acidosis is combining diarrhea has a normal anion gap. Anion gap may be estimated by subtracting serum chloride concentration from the serum sodium concentration. So acetozolamide therapy causes increased anion gap metabolic acidosis. So which one is correct? Hold please. Hold. So the credit goes to the Sanjay sir. So most of them are answering very nicely. We will end the poll. So the answer is, that is C, that is metabolic acidosis accompanying diarrhea has a normal anion gap. So anion gap is estimated by subtracting the sum of the chloride bicarbonate concentration from the serum sodium concentration. In the question, it was given wrongly. So the normal value is 10 to 12. It is a normal value. In the question, it is given as a abnormal value. Then the acidosis that occurs due to the gastrointestinal loss of bicarbonate ion with diarrhea has a normal anion gap because it is accompanied by a hyperchloremia. So diabetic acidosis has a high anion gap because the presence of increased levels of unmeasured anions, that is your acetoacetate and beta-hydroxybutyrate. Your acetozolamide causes metabolic acidosis with normal anion. So for a chronic respiratory acidosis, an increase in PaCO2 of 30 will result in a decrease in pH of 0.06 unit, 0.08, 0.09, 0.16, 0.24. The first question I have asked acute respiratory acidosis. Here it is chronic respiratory acidosis, the relation with the pH with the PaCO2. Poll please. So answer is poll please. So the pH change for acute respiratory acidosis is different from chronic respiratory acidosis. So all of you can participate in the poll. It is not to test your knowledge, but to deliver the knowledge. So you are struggling to answer in this question. So the answer is 0.09 units. For chronic respiratory acidosis, the pH will change 0.03 units for every 10 mm of changes of PaCO2. For acute respiratory acidosis, the change is 0.08 units for every 10 mm of PaCO2. So this is the clinching point. For acute respiratory acidosis, 0.08. For chronic respiratory acidosis, it is 0.03 pH because of the compensation come into play in the chronic respiratory acidosis. So the ability of the kidneys to compensate for chronic respiratory acidosis by excreting the acids and also retaining the filtered bicarbonate accounts for the difference between acute and chronic respiratory conditions. So the 9th question, the arterial blood gas finding that would confirm the Pickwickian syndrome is pH 7.44, PaCO2 44, PaO2 90, bicarbonate 24, or pH 7.35, PaCO2 44, PaO2 65, bicarbonate 26, or pH 7.42 or PaCO2 36. So you have started answering. So what is Pickwickian syndrome? It is a hypoventilation syndrome. So hypoventilation syndrome, what parameter you have to look? This is the clue for this answer. I think most of you picked my clue. Yes. So most of them correctly answered. So it is a hypoventilation syndrome. So automatically your bicarbonate, PCO2 level will be high. So in the given conditions, the D, that is PCO2 is 55 is the option of D. Others, the PCO2 is low. So the obesity hypoventilation syndrome is otherwise called Pickwickian syndrome. It's a state in which severely overweight patient fails to breathe rapidly and deeply, resulting in hypoxia and hypercarbia. So the Pickwickian syndrome is suspected. The most important initial test should be your estimation of the arterial carbon dioxide. So this requires either a ABG or a measurement of the bicarbonate levels in the venous blood. So expected ABG finding would reveal chronic compensatory respiratory acidosis. So coming to the last question, the mechanism by which the red blood cells maintain electrical neutrality while generating bicarbonate ions in the is termed as, that is, the red cell maintains electrical neutrality while generating bicarbonate. It is comes under the carbon dioxide transport system. Last week I have taken that. So it is a sodium shift, potassium shift, or calcium shift, or phosphate shift, or it is a chloride shift. Hold please. I have taken this in the last class. Yes, almost. Now, the participants have increased around 50%. So most of them answer correctly. So it is a chloride shift. So if you see this picture, so the gas exchange at the tissue level, carbon dioxide enters the RBC, it combines with water and carbonic acid is formed and it is dissociated bicarbonate and hydrogen ion. I have already said hemoglobin is a powerful buffer. It gives oxygen and combined with hydrogen ion. It buffers the hydrogen ion generated. This bicarbonate will be exchanged for the chloride. So this reverse happens at the lung alveoli. So this is called chloride shift. So this chloride shift is otherwise called Hamburger shift because of the Dutch physiologist Jacob Hamburger. You know, the normal saline we are using nowadays is this invented by the Hamburger only. So he is another credit goes to the Hamburger by introducing normal saline in the practice. So with that, we come to the end of the session. I thank you. I thank my colleagues, Dr. Gomadi Guru Sandhya, Prasad sir, Sarva Vinodini madam, Shantini and Jay Prakash sir. Thank you. Thank you once again. Thank you, Shilpa, for your fine coordination. We will meet next week with another interesting topic. Thank you. Thank you, Gomadi madam.
Thank you, sir. Thank you so much, sir.
Thank you all. Thank you.
Fine enough. Thank you. Shilpa, we can wind up. Thank you.